We
Okay.
have the honor of having Dr. Sanjeev Mahajan, the leading arthroplasty and orthopedic surgeon from Fortis Ludhiana. We also have the honor of Professor Leif, former professor, head of the department, University of Karolinska, who is the founder and board member of Episurf Medical AB, Stockholm, Sweden. Over to both of you. I'm sure you've got a lot of things to exchange about the new exciting thing in orthopedics, the patella femoral system.
The patella femoral system. Now, so this is our demo kit, and for many years we have had an implant for femoral cartilage lesions, focal lesions that are contained within normal cartilage. And so we have put, for example, in the trochlea we have a case like this, and this provides us with the possibility to use an oblong shape like that, and that shape could be really anyhow. And we make this patient specific, and then we put an implant in, and I can show you this. So this would be the oblong shape that can go anywhere. And so here you have the implant, and you see this is patient specific, shaped exactly to that patient's knee and to that lesion. So it can look like a corkscrew, it can be twisted in many different shapes. It's a chrome cobalt device. It's coated with titanium first, and on top of that hydroxyapatite. So it can be put in without cement, and it will grow into bone. And we've done that for 10 years now, and it's worked very nicely. So what we do here, our instrumentation is this thing here, and it will fit perfectly, and it will find one unique position, and then we pin that down with pins like this, chop, 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 and then we use first and this is an insert head that you can turn around like this. So we put this drill socket in, and then we have a drill that goes into here. First, to make a small hole, just a central hole.
Okay.
And then we put a drill socket in here. And you see these small markings here. And that enables us to, you put this in at the 0 position, and then you can twist it, and you put it in anyway, and by twisting it you increase the drill depth by 200 microns, 0.2 millimeter. And then you work your way down into the bone, and then you check with a dummy like this. Of course you turn it around, and then you drill your way down, and then you check with the dummy to see when you have reached the correct depth. Okay. Now in the case where you have a surface lesion in the cartilage, you want the implant to sit just slightly recessed below the cartilage. But in this new thing now, we are addressing osteoarthritis in this joint. So we do the same thing here, but we should probably aim at having the implant sitting flush with the bony surface. And then the new thing is the same concept for the patella, that the patella button, which looks like this. Oops. Here. So this is the patella button. This is also patient specific, fitting, of course, the trochlea of the patient. And the trochlea, and this implant fits a trochlea, and that implant fits this implant, which is all according to how the patient looks. This is plastic polyethylene. It is extremely high molecular weight, vitamin E enhanced. And so the same concept. the same concept that you pin this down. This finds a unique position like this, and then you have this device, and you have the drill like that. You drill it down, and then same thing here. You have the 0.2 millimeter incremental drill depth until you find the correct depth. You check with the dummy, and this is the dummy, of course. And this indicates rotation, and this is also, so this is the AP, and of course rotation is extremely important, that you get the rotation correct. And you should, before you remove this, you should mark this with a surgical pen. So we believe that our experience with the trochlea is 10 years old. We have had virtually thousands of operations. We found that this always fits perfectly. I mean, this is really mathematics. You know, you go from MRIs, and so I should show you this here, how we start with an MRI of the knee, and we do a damage marking report like this. So this is how that knee looks, the trochlea and the patella. And then in the damage marking report, we also have a set of MRI images that basically show you where we collected this information from. Let's say the relevant MRI, say 10, something like that. And then you have how the implant should go in to the implant. And here are the MRI images that go with the damage marking report. So you can see how these implants fit onto the bone, the projections of the implant into that particular slice. And then a final design. So this is delivered together with the implant in a small set. You know, you get a box days before surgery with all this stuff here for your patient, sterile, and you get this to the final design. So you can see how the trochlea is supposed to be addressed and how the patella is supposed to be addressed, how you should place these. And then these are the different sizes that we have. Both a solo in the trochlea, if that is all that's needed, or we have a combination, the twin we call it. And also, and I find this exciting, in cases where we have a dysplastic groove, we could improve on that. So we could actually provide you with an implant for the groove that moves the dysplastic groove to a normal groove. Now here what we do, we send this damage marking report to you over the net, and then you have a look at it and you say, okay, or you say, no, I want this to be somewhat differently placed. Okay, we say, well, we can do that. And then, so we communicate back and forth.
So how much time does it take to?
It takes, you will get the damage marking report within a week. So then we communicate over a day or two or something like that. And then if you say, okay, let's go for it, it takes another 4 weeks or possibly 5 weeks here.
So we ship from Sweden to here?
Yeah. So far, that's how we do it so far. We are discussing actually to set up shop here in India, but that is not for the time being. So, yeah, so this is...
Your experience in Sweden is with arthritic patients or with osteochondral lesions?
Our experience so far is with osteochondral lesions. I need to tell you that. We don't have a lot We don't have any follow-up data on the trochlea. It was launched in the US, this set, half a year ago. They've done a few cases, but that's just what I have to tell you. We don't have any follow-up data. We'd be interested in your follow-up data,
sure,
if you would provide us with that.
and say about numbers, and these are mainly done in younger patients or older patients?
Yes, we've with the osteochondral lesions, we say we aim for the gap age, patients that are older than, let's say, 35, because the biologists, I call them, they say that cells work well in the younger patients, but when after 35 years or something like that, the cells lose power. They say. And then on the other hand, you have the other extreme, you have the total knee, after 60, 65, 70 years. So the gap age between 35 and 65, let's say. Now, addressing the osteoarthritis, I think we are going to move up in age a bit, because it'll take a bit longer. I look at this, you may not agree, but I think the OA in the knee, in the trochlea or in the femoral-tibial joint starts with a cartilage lesion, an osteochondral lesion, traumatic. And then that grows over. They talk about, potholing, like, potholes in a road. You drive over it and it expands. And that's how osteoarthritis spreads. But it's a slow process. It takes decades, basically. And so I believe the patients that we see with osteoarthritis here will be older, but we just discussed that here. Then you have the young females with dysplastic trochlea. And in Sweden, we often see them when they are, they are still teenagers. Sometimes they dislocate. And we do all sorts of soft tissue releases or tuberosity replacements, and they don't work, and they come back 15 years later, and then they are 35 years old with osteoarthritis, here. And we have to do.
In our clinical setting, we see a patient, a young patient with a knee pain, mainly anterior knee pain.
Yeah.
X-rays shows maybe a mild wear up.
Yeah.
And the cartilage is well preserved. We get an MRI.
Yeah.
We find a lesion there, and we find a small meniscus which is damaged. Say, one horn is gone, and some cartilage lesion on the medial side, some cartilage lesion on the patellar side.
Yeah.
In my practice, I don't tell them surgery. I treat them conservatively. I don't jump onto the meniscus. I wait. Conservative try. If the varus is more than 10 degrees, I don't do meniscus. If it is within limits, less than 10 degrees, I do scopy and we clean up meniscus and everything. Do you think that is helpful in planning for this type of surgeries? I find a lesion, I do a meniscus, I come out and I see a big lesion sitting around the patella and in the notch. So what I do presently is I suggest them bone marrow or PRPs. At times it works.
Well, I would suggest, and that's how we do in Sweden, we stay conservative all the time. We in the early days for these young women, we try physiotherapy, to strengthen their medial vastus. It works sometimes, but we scope them. Yes, we do shaving, shaving of the patella and of the cartilage, and it may work. We keep them going, but eventually, when everything is depleted, you can't do anything more. Yes, I think that. And I don't think anything you do will detract from the possibility for this to work when that time comes. I would suggest.
This is required in a few patients where nothing else is working. You're trying to
Yes.
Those patients, I don't have any experience, but they might work. They might be benefited by this type of surgeries.
Yes, yes. I mean, at the moment, I must agree with you. It may work because I don't know any better. But there are a number of implants like this on the market that seem to work reasonably well. We believe that, and I'm quite excited about this, the fact that this is patient specific. I don't know of any other patella button that is patient specific, because all the patella buttons that I put in my career, they're just a blob. No particular shape at all. And you put it there to replace it with, for that reason I think possibly that this may work better. I would be very excited if you would find a patient.
I'll try. But the question to the Indian team is that is it approved by the Indian government?
Yeah, we have already implanted 7 implants in India after the CDSU approval. And Professor Leif is operating in Jaipur on Sunday and on Tuesday in Delhi for the Palace. And we've done 2 knee, one during the ISCON in Coimbatore 2022 and one with Dr. Dinsha Padwan at the same time. And in any case, it's a patient-specific approval we take. So we take your prescription, we take your letter, and then we get the patient-specific approval also. So,
And how much is the cost like?
for the whole implant is 3,500 euros, which roughly works out to 3 lakhs.
And this will take approximately 4 weeks.
4 weeks, yeah.
And do the insurance companies reimburse this?
Right now it is not insured. I mean, the implant is not insured, and we are working with the IRD authorities to give this preference like what we did for me. And
Great.
Thank you.
Thank you.
Thank you.